Hello, everybody. My name is Mark Coronel, and welcome to the UCLA Health Core Kidney Program Monthly Chat. Today, we're going to be discussing on kidney transplant and what you should know. It's National Kidney Month as well, and I'm excited to share all the information that's coming in today from leading doctors in the transplantation world at UCLA Health, and just being excited because it is that month as a kidney transplant recipient. I'm here now 3 years out, and I'm excited to bring the information that's coming on today. Just as a disclaimer, to the information contained in these topics is not intended nor implied to be a substitute for professional medical advice. It is provided for educational purpose only. The UCLA Health System, nor the providers in the information contained herein, including all parties connected with this event program, cannot guarantee the accuracy of such information. You assume full responsibility for how you choose to use this information. Always seek the advice of your physician or other qualified healthcare providers before starting any new treatment or discontinuing an existing treatment. Talk with your healthcare providers about any questions you may have regarding a medical condition. Nothing contained in these topics is intended to be used for medical diagnosis or treatment. And I'd like to introduce you guys to our Core Kidney Health Program, the Circle of Core. We are ambassadors dedicated of, recipients, caregivers, and donors, all having stories to share about our journey going through kidney health. And with that, I would love to share Dr. Sarkar and bring her on board to discuss about the transplantation and what you should know.
All right. Hi, everybody. I'm Molly. Welcome to the monthly chat. This is March. This is the National Kidney Month. We are incredibly excited to have today two very, very notable transplant nephrologists with us, discussing about both the basics as well as the new and up and coming things in transplantation. So really excited for today. So first, I would love to introduce Dr. Tariq Shah. Dr. Shah has a long history of being a very successful transplant nephrologist. He was the medical director at St. Vincent's for over 30 years, led the transplant program there, very, very successful. We've been blessed to have him now join us in UCLA, and he will be introducing and talking to you about the basics of transplantation. And the second very important guest we have today is Dr. Eric Blum, who is joining us from the UCLA transplant program as well. And he serves there as the director of the complicated transplant. So we're going to have him talk to us about the new up and coming things, the tolerance program, which is the immunosuppression-free protocols that UCLA is doing right now. And he also takes care of the HLA incompatible transplants up at UCLA. So really excited. And now I'm going to hand over the mic as well as the podium to Dr. Shah to drive this PowerPoint and tell you guys about transplantation.
Okay, good afternoon, everybody. Dr. Sarkar, thank you very much for that kind of introduction. My job here is to give you a general overview of transplantation, kidney transplantation, as we're talking about specifically here. And I like to keep it very simple and understandable. Certainly, please feel free to ask questions as we go along, or save them for the later part of the talk. Let me start by saying that kidney transplantation has been a game changer for patients with chronic kidney disease. Just to set the stage, we call it chronic kidney disease because it is a slowly progressive ailment of the kidneys where the body is unable to perform the normal functions of the kidney and goes through stages, stage 1, 2, 3, 4, 5, 5 meaning end stage renal disease, needing some form of replacement therapy. And we have dialysis, both hemodialysis and peritoneal dialysis, and we have kidney transplantation. And we'll elaborate on that. So kidney transplantation is a proven method to treat kidney failure. It is the optimal treatment. It is a surgery, as with any surgery. The pros and cons of surgeries come along with it. And it's a lifelong commitment from the patient standpoint to care for this transplanted organ, because it's a gift, really a gift of life, the kidney transplant, be it from a deceased donor or a living donor. And of course, it's a partnership between the patient, their families, and the transplant centers and the personnel in the transplant centers to lead them across this journey successfully. Next slide, please. So, as I alluded to earlier, the kidney function is not simply to filter blood and out comes urine along with the toxins that are not needed in the body. The kidneys have a number of other functions. Kidneys are the main organs that regulate blood pressure. So when the kidneys start failing, that blood pressure regulation goes haywire in patients have high blood pressure. And sometimes high blood pressure leads to kidney failure, or when the patients have kidney failure from another cause, it causes high blood pressure. It's kind of like a chicken and egg. Kidneys also produce erythropoietin, as you know, which is the ingredient in the red blood cells that carries oxygen to the tissues, the life-saving. So when kidneys start failing, patients start having less hemoglobin production, less erythropoietin production, they become anemic. Kidneys are the main organs that maintain acid-base balance in our body and the fluid balance in the body. We all talk about hydration and dehydration. You know, kidneys keep us in equilibrium in that regard. And then kidneys are main organs that maintain the calcium phosphorus balance and keep us healthy. So when kidneys start failing, all of these systems start going failing, and we have to address all of those issues. Fortunately, in this kidney failure system, we have modalities to replace the kidney function, which is by dialysis, both hemodialysis and peritoneal dialysis. While not ideal, they sustain life. And kidney transplantation is a proven method, optimal method of maintaining kidney function or replacing kidney function. Next, please. And this is just to show all dialysis patients know this all too well. You know, you have to go to dialysis. The best of dialysis gives you maybe 10 or 15% of kidney function. And that's just the filtration function of the kidney. Not all the other functions that I showed you in the previous slide. We need medications and strategies to address those other issues that come with kidney failure. And moreover, it's a cumbersome thing. You know, patients have to go to dialysis at least 3 times a week for 3.5 or 4 hours. They're tied down to this chair and so on and so forth. So it impacts the general life and lifestyle. Next. And, you know, as I alluded to earlier, kidney transplantation is the renal replacement of choice for better health. It is proven that kidney transplantation improves the life of kidney disease patients, end-stage renal disease patients, and that it's across the board, across all age groups, across all etiologies of kidney failure, be the kidney failure from diabetes or some other cause of kidney failure. Kidney transplantation is superior than dialysis. Next. And it's not just superior and healthier for the patients, it is also more cost effective. As you can see, the kidney transplant on the left-hand side, in terms of expenditure of healthcare dollars, is much cheaper than hemodialysis. As years go on, it may be a little more expensive immediately in the post-transplant period, but it evens out within the first year and then becomes a lot more cheaper. So it's a win-win situation. Patients are healthier and there's more healthcare savings. When kidneys fail, I mean, the kidney transplant has a life, and as Dr. Long will talk in his talk, we'll talk about all of that. But if there is a graft failure and return to dialysis, that is also fraught with increased expenditures. Next. So let's compare dialysis versus transplant. As I said, we're fortunate that we do have modalities of renal replacement therapy, such as hemodialysis, peritoneal dialysis, but kidney transplantation is superior. So with dialysis, as I showed you in that beginning slide, kidneys have many other functions. So calcium phosphorus balance. So when you're on dialysis, you have dietary restrictions because your phosphorus goes up. So patients are told no milk products, just mocha mix, no soda, so on and so forth. Fluid restriction, intradialytic weight gains, all dialysis patients know this really well. And because they're anemic and they have these uremic toxins still, as I said, the best of dialysis gives you only 10 to 15% of kidney function, and that's just filtration function. They have this lack of energy and fatigue, not just from anemia, but from general uremic thing. So all of these things get better with a well-functioning kidney transplant. Next, please. So we'll switch gears and talk about the transplant process. So we have a team. It takes a village, right? We have a team that guides the patient across this journey of transplantation. It starts with pre-transplant education, and the pre-transplant education should start early on. When the patients encounter chronic kidney disease or kidney failure, of course, they are with their primary physician and their nephrologist. The dialogue should start right there when the kidney disease is at stage 3 or approaching 4, so that the patient is well prepared. I always like to say, we don't dig a well when there's fire. We have to be well prepared for that. So the patient goes through this initial evaluation, is referred to a transplant center, and then there's a chain of events that takes place to get the patient to a listing. And then, the choice of kidney transplant is twofold: deceased donor kidney transplant and living donor transplant. And now there's a finite pool of deceased donor organs there, cadaveric organs there, and there's a discrepancy between supply and demand. As of this morning, nearly 90,000 patients are waiting for a kidney transplant, but there's only so many deceased donor kidney transplants that are available. And then we have this choice of living donor. We need to improvise on that. Of course, that's the best kind of kidney transplant is a living donor transplant. And then once the patient undergoes all the evaluation process and gets listed for a transplant, then the clock starts ticking and they wait for the transplant. If they have a living donor transplant, there's no waiting period. The waiting is only as long as it takes for the donor and the recipient to be evaluated. Otherwise, the waiting list for a deceased donor kidney transplant, it varies in different geographic regions of the United States, but in our area, it's more than 7 to 8 years. Then we can talk about pre-transplant care, the transplant itself, and the post-transplant care, which is very important. Next. So as I said, the discrepancy between the supply and demand, nearly close to 90,000 patients waiting for their kidney transplant, and only so many deceased donor kidneys in the pool. We have to be innovative to narrow this gap and give more patients access to transplantation. So the pool we can increase is the living donors. And then there are certain challenges to living donation. For example, if patients are incompatible, as Dr. Sarkar said in the beginning, and Dr. Lum will elaborate on that with his exciting work, we have paired exchange. For example, a patient has a loved one who is willing to donate, but for some reason or the other, they are not compatible. And somewhere else, there's a similar scenario, they can undergo a paired exchange. And directed donation. I already spoke about the deceased donation pool. Next. So who qualifies for a kidney transplant? All patients with when they approach end-stage renal disease, they are candidates for kidney transplant. They can be listed when the kidney function is 20% or less. But there are certain, you can keep going, please. There are certain absolute contraindications to transplant, which is, if they have cancer, active cancer, next. Active infection, next. You can keep going, please. Advance, advance, and advance. So all of these are, contraindications to transplant, but most of them are relative now. That's why I said we need to evaluate patients early on so we can address all these issues for those patients that have it. So who can donate a kidney? Anybody healthy, age 18 or over, because that is the age of consent, can donate a kidney. So it doesn't have to be an actual relative. It could be anybody amongst relatives or unrelated, or even altruistic donors, strangers. You've all heard about stories, how this happens. So donor evaluation happens by a special physician in the transplant center. All transplant centers have a donor advocate that guides them through the process, and the donor evaluation process for the physician is done thoroughly. Next. And the deceased donor is cadaveric kidney. Again, as I said, there's a finite pool there, and we have to be innovative about decreasing the supply and demand. And to that end, we have become more savvy with accepting organs that we might have considered marginal in the years past, with improved surgical techniques, improved medical management. I think we are using those organs and keeping them successfully transplanted in the patients. Next. So when we talk about matching, people often ask, what do you mean by matching? And very simplistically, I tell patients, it's just like blood transfusion. You have to be blood group A, B, O compatible. And then we have immunological testing of this HLA. You have to have HLA matching. And again, all of that is not set in stone now. We have actually crossed those barriers as well. But just for educational purposes, this is what HLA means. Next. Then we have class 1 antigens, A, B, and C. Next. And class 2 antigens. You'll hear about these from your transplant centers. And this is what it means. Class 1, class 2, HLA, A, B, C, DR, DP, DQ. And they'll tell you are a 1 match, 2 match, 3 match, or a 0 mismatch, or a 6 antigen match. You'll hear these in these sentences talked about quite often, but that's what it means. Next. And again, the match between the donor and recipient can be from 0 complete mismatch to a 6 antigen match. And then we undergo cross matching, which basically means you take donor and recipient blood and cells and see if there is a reaction or rejection in the laboratory. And if the cross match is negative, that's a good thing. Negative in this case meaning good, which means proceed with transplant. Next. Next. And I leave the ABO compatibility for Dr. Lum, but in straightforward transplants, the patients are ABO compatible, and then the cross match is negative. We proceed with the transplant, kidney transplant. Next. It is well known that more matches on the HLA, the better the graft outcome. But because we are so advanced in the science of transplantation and medical management of this is becoming less and less more important now. And you'll see the cutting edge medicine that is being practiced in the transplant world in the next speaker. Next. So suffice it to say, more antigen matching, the better outcome. For example, identical twins would be an ideal situation for the best outcomes for the transplant, but we don't have that luxury all the time. And again, we have become very advanced in medical management of these patients to, get across this HLA mismatch. Next. Thank you. Keep going. And as I said, this is contraindications to renal transplant. And I want to say this is relative contraindications. So ABO incompatibility, you'll see how we're pushing the envelope now. And positive cross-match, also you'll see what strategies we have to address that, negate a cross-match and proceed with the transplant. But patients with active malignancy, active infections, and all of these things are contraindication until they are resolved. Next. So now that we spoke about the basics of transplant, patient has chronic kidney disease and they're approaching end-stage renal disease. If their filtration function, or what we call GFR or kidney function, is 20% or less, they are eligible to be listed for a transplant. Then, if they don't go on dialysis, they can get what we call a preemptive transplant. But if they get on dialysis, then they wait for that magic phone call where they get a deceased donor transplant. But if they have a living donor transplant, then that waiting time is cut short. But regardless, and generally, patients require anti-rejection medications or what we call immunosuppressive medications. I like to call them immunomodulations because we are tweaking the immune system to a point where it allows the body to accept the transplant without rejecting it and without risking too much risk of infections or cancers or anything that immune surveillance keeps us healthy in the body. So these are the common medications used after transplant. Usually patients are kept on 3 or 2 medications after transplant for the duration of the transplant for life. So Prograf or tacrolimus, Celsipta or mycophenolate, steroid in the form of prednisone, and then there are other medications like rapamune, belatacept. Early on in the transplant phase, during the hospitalization, we give patients intravenous thymoglobulin and steroids. And then to prevent infections, we use these medications such as valcide-bactrim, etc., to prevent infections. So this is a general life of a post-transplant patient. Next. And you can keep going through this. I've already spoken about most of this. And these are the factors that influence the longevity of the transplant. Next. I think I'm at the tail end of my talk here, but I want to conclude by saying the life changes after transplant. Again, I'll go back, not to sound like a broken record, but the best of dialysis gives you about maybe 10-15% of kidney function, and that's just not all the functions. And the challenges with dialysis, the constraints with dialysis, going to a dialysis unit 3 times a week, or 3.5-4 hours, or doing peritoneal dialysis, whether you do it at home and if you're traveling, all the challenges that come with dialysis. When you get a transplant, with a successful transplant, there's no further need for dialysis. And all of those cumbersome things go away. You get a lot more energy, you're back to normal. All those other functions that the kidney has, namely making oxygen, higher oxygen carrying capacity by making erythropoietin. You don't need that after transplant. There's no fluid restriction. Your diet is more liberal, none of that, your phosphorus. Again, you actually have to chase it the other way. And all of these things improve that I've listed there, and this list is not complete, but all of these things improve after a successful kidney transplant. But again, it is a commitment, kidney transplant. It is a commitment. When I say compliance, compliance means, we work as partners, the patients with their healthcare team, following the instructions. Again, anti-rejection medications or immunosuppression for life. Now, this may not hold true as we move forward in the next few years, and you'll hear again from the next speaker on this. This is some very exciting work. What I like to say is, this immunosuppression for life, I like to tell patients it's a double-edged sword, right? For example, tacrolimus or Prograf, which is the mainstay of anti-rejection medications, they're good. They prevent kidneys from rejecting and keep them healthy, but yet over a period of time, they kind of cause scarring in the kidney. But it's an evil, necessary evil. The kidney kind of becomes like, I like to use the analogy of an older car. The car is 10 years, 15 years old. It has wear and tear. Likewise, kidneys have wear and tear from there's not just the age process of it, but the anti-rejection medications that we use. Not sure if we have any questions at this point in time, because I've been talking all along so far. I'm sure they are, and I can take some right now.
Dr. Shah, thank you so much. I wanted to ask you a little bit, kidney disease is often referred to as a silent killer because symptoms appear only when kidneys are already damaged. Can you give us some examples of signs and symptoms we can look out for?
Yes, Mark, you put it really well. It is a silent disease, silent killer. It doesn't make itself known like a rash or a cough. It's the same thing for hypertension, right? High blood pressure. The commonest causes of kidney issues in North America and world over are diabetes, high blood pressure, right? And again, those are silent diseases, silent killers, until and unless something triggers a evaluation. It has been going on for a long time. The same thing with kidney failure. But by the time the kidney failure has advanced, fatigue, for example, unusual fatigue, that might lead to an evaluation. Or sometimes patients notice change in their urination, or some even have foamy urine or things like that. Those should be, telltale signs. But you're right; it is a silent disease.
Right. Now on transplantation, I know that we explain the process. Now, when a person goes through it, what is the average wait time from beginning to end till we're actually on the transplant bed and getting ready for a kidney transplant?
Yes. So again, we have to break it down by deceased donor kidney transplant, the cadaver kidney transplant. As I explained at the outset, there is a big gap between the supply and demand. Nearly 90,000 patients are waiting for kidney transplant, and there's only a finite number of organs around. That's why waiting times for deceased donor or cadaveric kidney transplants are high, and they vary in different regions of the United States across the country. Our country, for transplant standpoint, is divided into regions, and Region 5, our region over here, it's quite high. The transplant, a person could wait for transplant anywhere from 5 to 8 or 9 years. But having said that, sometimes patients come and get listed and they get a call within the first year. Or sometimes patients are on the list for 10 years and nothing has happened. So yes, it's a mixed bag, and a number of factors come into play there. And number two is the living donor transplant. So really, the only time there is as long as it takes for the donor to be evaluated and the patient to be evaluated, and then the surgeries to be scheduled. So that's an ideal form of transplantation in that context, Mark.
That's amazing. That's amazing, Dr. Shah. I got another question for you.
Please.
Are there any lifestyle changes that a patient needs to make after a kidney transplant?
Their life actually gets a lot better in terms of energy. not just physical energy, the mental status gets better, their sleep patterns improve, and they're able to pursue hobbies, pursue vocations, get back into their jobs. So I think the lifestyle actually improves every which way. It is just the compliance and the anti-rejection medications for life. So what I like to tell patients is it's a great reward to get a kidney transplant and have all this healthy life, but their life is also becomes a little more regimented. I'm glad you brought this up. It becomes a little more regimented in the sense we always want patients to follow all the advice regarding medications and lifestyle we tell them. But life is life, it's not always 100% possible. And I'll give you an example. A patient is on dialysis, is asked to take their phosphate binders or just drink this much or take only this much sodium so that they don't have too many weight gains in between dialysis sessions. And if they miss 3 or 4 phosphorus pills 2 or 3 days later, probably nothing bad will happen. But unfortunately, this anti-rejection medications, if they miss 1 or 2 or even 3 doses, they risk rejection. And it does happen. So in that context, it becomes a little more regimented. And who knows, with the cutting edge medicine and great work of Dr. Lum and colleagues, that may change. But for now, yes, their life becomes regimented in that sense.
Amazing. Thank you, Dr. Shah. Now, are we bringing on Dr. Lum to give him his, to understand what Dr. Lum was discussing about making transplantation without a lifelong regimen of anti-rejection drugs a reality at UCLA Health?
Yeah, Mark, I am going to introduce. So everybody has been calling, questioning, and talking about what it is to be immunosuppression free and still have a transplant. It is a very exciting world, and I am proud that Dr. Lum could join us and talk about it more today. So Dr. Lum, I'm going to push it to you. Let us know how we should drive your slides.
Thank you very much, Molly, for inviting me. It's a great pleasure to be involved with Kidney Core and give a talk today about one of the amazing projects that we have at UCLA that currently right now is the only functioning program in the entire United States providing this service for patients. I guess next slide. They don't need to look at my picture. So what is this project we're doing here at UCLA? It's called the Kidney Transplant Tolerance Program. And basically what it means, like Dr. Shah had said, we all feel that kidney transplantation is something that for patients provides a much better quality of life, a longer potential lifespan for them to spend with family and do the things that they love rather than being stuck on dialysis in a unit for hours a week or plugged in at night on peritoneal dialysis. And so, transplantation is remarkable if you think about it. We are giving you someone else's organ, this wonderful gift, and you're able to keep that organ that you're not born with by the sheer medical marvel of immunosuppressive drugs. They are wonderful things that patients can experience. But our drugs are not perfect, as Dr. Shah had alluded to. They can cause kidney injury. They have an increased risk to develop diabetes for patients who are not diabetic over a very long period of time, because people are fortunate enough to keep their kidneys for 10, 15, 20, even 30. I think our longest here at UCLA is over 52 years, without returning to dialysis. It's wonderful, but you are exposed to these medications and the regimen of these medications for the rest of the transplant life. And so our program here at UCLA is trying to take what is already excellent and try to make it better for patients. And the goal of this program is really to provide patients with a kidney transplant without the lifelong need of immunosuppression. Now, I will say as a front to start out with, It does not mean no immunosuppression off the bat. It does mean potentially at about a year post-transplant, not needing any medicines afterwards. And that's what our program is aimed trying to do. Next slide, please. So our program is a unique multidisciplinary program. It involves many subspecialties. Typically, for a normal transplant recipient, you're kind of managed by the transplant nephrologists like Dr. Shah, Dr. Sarkar, myself, Dr. Danovich, and our surgical team. But because of the way we this project works and what we end up actually doing is reprogramming the immune system to accept another person's kidney as self. So you're basically reprogramming the immune system to be yourself and whoever donated your kidney. We need other specialists to help us out. So we have world-renowned specialists in hematology, radiation oncology, surgical colleagues, myself, clinical research team, plasmapheresis team, and there's a lot of people that are involved in this particular project that are beyond the typical transplant involvement. And the primary goal of our program is really to eliminate maintenance drugs and preserve kidney function. So what that means for patients is you walk around and you don't have to take the anti-rejection medicines at all. I mean, you may have to take other medicines if you have other medical problems, but nothing for the kidney itself. In our program, as I mentioned earlier, we're actually only active 2 haplotolerance. This is just a fancy medical term, but what it means is well-matched pairs. So a sibling where you have the same mom and dad, you have a 1 in 4 chance of being a perfect match. If you have a sibling, and that is a perfect match, you could potentially go through this program. And that's the active program that we have right now. And we are the only active program in the United States. We have, I think, done a total of 6, 2 of which are from out of state, 1 from Oregon and the other from Georgia, who heard about our program and kind of traveled over here to undergo this program. Next slide, please. So how this works is we basically take stem cells from the same donor who gives you the kidney, and patients who receive the kidney undergo what we call conditioning. If you Google that, it'll look very scary to you, but basically what we're trying to do is 2 things. Is we put the kidney in first, and everything's kind of standard as a kidney transplant would be. But in order to reprogram the immune system, the way we do it is a process we call medically called central tolerance. But for the layman, it's basically we're trying to reprogram the immune system to become a double immune system, one that's yourself, and then another part of the immune system which belongs to the donor. And this double immune system, from what we've seen, does not have to last forever. It just has to last us for at least 6 to 9 months, and we can still get patients off immunosuppressive drugs. And the way we get a double immune system is that we give stem cells from the donor. Now, I think next slide, please. The process requires a little bit more treatment than a standard kidney transplant, but the potential benefits are huge. So in order for us to make sure the stem cells are not rejected, because they are different person's tissue. If you just inject stem cells into, say, myself or Mark or Dr. Sarkar, our immune system is just going to see that and start to attack it. So we need to suppress the immune system so that the stem cells can survive. So we give patients special treatments starting at the beginning of their kidney transplant, which is day 0. And that's what this ATG is at the beginning. Now, it's not just good enough to make sure we don't reject the stem cells. The stem cells, when they're injected, they have to find a home to sit in. And if there's no home to sit in, they just kind of float around and eventually die off. So in order to create a home for patients to sit in, we actually have patients undergo radiation therapy to their bone marrow. That's this little picture on the upper left, but it's basically irradiating the bone marrow to create some space for those stem cells to land and then grow and thrive, and then help the patient who gets this transplant develop a dual immune system. Now, radiation is obviously something that's, I think, very scary for patients. It's often, as you know, people think, well, I'm getting radiated, it's for cancer, I'm going to glow, you know, like the Hulk or something like that. But the dosing we use is about 1/10 the dosing of what typical patients use for cancer treatments. So we're just giving a little radiation to just open up enough space for those stem cells to have a home and to grow in. And basically what we do is after that's done, people get 10 treatments. 12 days after their kidney transplant, they will get their donor stem cells. The donor donates their stem cells about a month before donating their kidney, and we do some treatments to that. And patients are essentially on prednisone, which I know many patients don't like to be on, for only 10 days. And after the stem cell infusion, we do start another medication called mycophenolate. It's another anti-rejection drug for a brief period of time, for a month. And over this entire period, they're on our main anti-rejection drug called tacrolimus. And that is tapered over, it's actually tapered over 45 to 48 weeks. The months is where we broke into 4 weeks for the study. And patients are allowed to continue to lower their anti-rejection drugs if we find that there are two immune systems. So when we look at the blood test, that we can tell that there are blood immune cells from yourself and your donor. And there's no evidence of rejection of the kidney, and there's no evidence of something called graft versus host disease. So one of the concerns with this particular process is that if we reprogram the immune system too much, which is to say we get rid of your own immune system and it's all donor, you won't reject the kidney, but you will get a condition called graft versus host disease. And that is a very serious disease. We have not seen it in any of our patients. This was all pioneered at Stanford University, where I was a trainee and I worked before I moved to UCLA. And they have about 22 patients that they've done. They've subsequently shut down their program. And about 80% of those patients are off all anti-rejection medicines. Next slide, please. In terms of how our patients are doing, we have currently done 6 patients. 2 patients have been off drug for over a year now. Our very first patient, you can like do a YouTube. I think there's a video at UCLA Health, so I can tell you the name without HIPAA stuff. But Mr. Macias, he received a kidney transplant from his brother. And he's been off drug for about 14 months now. So he went through transplant, went through this whole process, and he has not been on any anti-rejection drugs for over 1 year now. He's doing well and no evidence of rejection. And he has got excellent kidney function with a creatinine of 0.7 eGFR for those who follow over 89. Our second patient has also been off, I think, a year now. He received it from his sister. He was actually on the Rose Bowl parade float this year for Donate Life, which won first place, I think, this year. And he's off all immunosuppressive medications as well. His only medication, actually, oddly enough, for those of you who suffer through kidney disease, one of the things we see with transplant is that it's like the opposite in terms of phosphorus. Many of you have to take binders or restrict your diet so that phosphorus levels don't build up. Oftentimes with kidney transplant, there's a lot of phosphorus wasting. So we're doing the exact opposite of what we've taught patients while they're waiting for their kidney transplant. We're telling them to eat a bunch of phosphorus. So this gentleman is actually on phosphorus supplements, and that's it. But he can't eat enough phosphorus, which I guess is not too bad of a problem to have. Our third patient, she's doing well. She's actually, I saw her today. She's only on cyclosporin, which is an alternative drug to tacrolimus, but she's actually only on 1 pill a day of 25 milligrams. Her creatinine is excellent. It's 0.8. And all these patients have evidence of dual or immune systems. And she is feeling well. And in about 3 weeks, we plan to take her off all drug entirely. She did have a little bit of infection, which is not unexpected. Because she was on anti-rejection medicines at the very beginning. She carries the same risk as every other chronic long-term transplant patient and to develop a small virus reactivation. But that has been resolved and she's doing well. Our fourth patient is doing well. He's 7 months post this procedure. He's only on one drug, the tacrolimus, and his goal level is 4, so he's tapering down. He's doing well. He's living life like normal. For all you who want to know, I mean, he basically was like snowboarding 2 weeks ago with his son, who's 15, and he hadn't been able to do that because he just didn't have the energy. That question that Dr. Shah so expertly kind of answered, these symptoms of kidney disease, low energy, you're there, but he felt like he wasn't really there for his family. He could do the things that were necessary to work, but now he has this energy to go teach his son snowboarding. Although I told him to wear a helmet. So, do things like that, but he's enjoying life. Our fifth patient, who's from Oregon, he is also on tacrolimus only. He's 4 months out. He also had some minor infection reactivation, which resolved on its own, and he's doing well. And our sixth patient, she's actually now 3 weeks out of her stem cell infusion. She's doing well. The main issue that we are seeing is that because of radiation and some of the medicines, the white blood cell count and the hemoglobin take a little bit more time to recover, although patients' energy levels are good. And we have not seen any of this concern for graft versus host disease. We do plan to enroll 15 total patients for the study, and then I think we have kind of funding for afterwards. So it's something exciting that we hopefully continue to do and gain more experience in and be able to help a lot of patients with this. Next slide, please. Now, the problem, I would say the problem with our protocol is it only helps a very small percentage of patients, and we want to be able to help more patients. So we want to be able to move beyond just well-matched siblings, and we do have an FDA-approved protocol, and we're just kind of, I guess for lack of a better word, slogging through all the regulatory processes that are required for patient safety. So they're very important, but we hope soon to open up a protocol for not as well-matched patients. Now, for those of you savvy enough, if you Google some of these programs, they've previously been available underneath a company called Tolaris. They had enrolled 22 patients for this mismatch. We were not part of that program, but they have subsequently, as of 2 weeks ago, shut down that program nationally. And part of that is because they saw out of their 7 that they did, so they enrolled 22, 3 patients developed this graft versus host disease, and 1 patient actually unfortunately died from it. And so because of the safety profile, they basically decided not to move on. So once our program opens, we will be the only program for this. Now, this particular program, because we're just starting off and we want to avoid graft versus host disease, we've actually created an entirely different protocol than other centers who have done this, but it uses an oral medicine that actually is FDA approved for graft versus host disease and also alters the immune system to produce what we call tolerance, which is it increases a certain type of immune cell that allows that we've seen in models, human pilot trials and animal trials, where there's more data that this helps to allow for the immune, like a coexistence with of immune systems. So we're hoping that this will help us get better results Because the results are different for less well-matched pairs, our tapering protocol is a little different. Patients will undergo a similar preparatory phase before their stem cells at 2 weeks, but they will keep the prednisone for 6 months, mycophenolate for a year, and then we will get them off the tacrolimus in slowing and lowering levels by 18 months. And so we hope to open that up soon. Next slide, please. And in order to really move this to even more patients, what we've done at UCLA, and our hope one day is to get this to deceased donors. And part of the reason we're doing this all in parallel or this is because if we did it piecemeal, I don't think I'm going to be, I'll be retired by the time you be able to do everything. So we want to help people more quickly, provide them that promise, but not kind of just dangle this carrot and say it's never going to be done for 10 or 15 years. We want to be able to move this in our lifetimes and for patients who need this. So one thing we've shown actually is that we were able to get stem cells from deceased donors without affecting the organ quality that could be donated. So one of the main concerns is that if we get stem cells from a deceased donor is that, well, you get stem cells, but you could affect the heart, the lungs, the liver. And so, by getting stem cells, you may not be able to help, these eight people who could benefit from life-saving organs. And so, we are working with our local organ procurement organization, which is a nonprofit called One Legacy. And we have taken donors who could not donate for whatever reason. For example, one had kind of cancer and the family wanted to donate, but we don't donate, we don't let patients who have cancer donate their organs because we don't want to transmit that cancer to a recipient who gets an organ that needs immunosuppression and then could pass away of cancer. So that family still wanted to try to help transplant recipients, and this was a way that they felt they could help, is being involved in this study. And we've published this data showing that we can get stem cells safely in a better way than we can currently get them. The current way is very disfiguring, and there's a lot of contamination, which is to say you can't rely on getting stem cells in that fashion. And one of the newer exciting things that we have for those of you who already have a transplant here and are wondering, well, shucks, I missed my boat. I had a kidney transplant 1 year ago and we're well matched. Now I'm stuck with immunosuppressive drugs. Like, it's great that you're helping everyone else out, but I wish I could be helped out. So one thing we're doing, and we have done, and we have to wait to see the results, is we did our first ever, as far as we know, in the entire world, what we call delayed stem cell transplant. We had a patient who is a young man, matched well with his brother, got a kidney transplant. He's doing great, feels wonderful, back to work. I mean, this is a 25-year-old kid who was like, I was laying on the ground because I had no energy. Dialysis was there. It was great, doc. It was keeping me alive, but I felt like it was just keeping me alive. I wasn't thriving. Now, he's back to work. He's doing all these things. And he said, look, is there a way that I could not be on these drugs? I'm 25 years old. I'm supposed to be 75. You want me to have 50 years of immunosuppressive drugs? I don't know what that's going to do for me. I won't do anything in 5 years, but when I'm 45, 50, 55, 60, what am I going to be dealing with? So he agreed to be part of our program, which we just launched for patients who are between 3 years post-transplant and 10 years post-transplant, who are well matched, again, those sibling donors, to get his brother's donor cells. So he already got his donor kidney. Then he went up to him and asked for his stem cells. But he asked for his brother's stem cells. His brother agreed. And we did this process where we gave him this special medicine to prep his body to accept the stem cells. We did the radiation, and he got his stem cells last week, and he's doing great. Now what we have to see is in 4 weeks of whether he has this kind of dual immune system. I will say that he was on 2 medications, tacrolimus and mycophenolate, kind of chronically. That was his his long-term immunosuppression, and now he's basically off. He got some prednisone. He's off of it. Little mycophenolate and tacrolimus, and in 4 weeks, if he has evidence of 2 immune systems, we'll be able to lower his drugs down. Oops, hello? A question? No, okay. I'm almost done. And so he is kind of this, we've built this rocket ship and he's brave enough to be this astronaut and load himself up. One of the reasons why this is important is because for a deceased donor, there's no stem cell lab that can do a 2-week turnaround to process the stem cells and make sure they're safe for infusion into a patient. So if we can do this, we can open it up to patients, potentially deceased donors, but other patients who've undergone transplant and wish to undergo this program. So I know we only have like 3 minutes left, so I will turn this over to Mark and see if there's any questions I can answer. And Molly, Dr. Sarkar.
I think there's one, Dr. Lam, which you already alluded to with the delayed tolerance, but Brock asked, do you think you'll be able to do this treatment in post-transplant patients at some point? So I think you very well answered.
So we're doing it, and hopefully the first guy does well. and we can update everyone.
All right, somebody raised their hand if they can ask the question. I don't know if they want to type the question. Mary?
Yes, I'm looking for that question. Yeah, Dr. Lum, thank you so much. I mean, it's amazing to hear this. And I was actually, as a patient myself, I was like, well, do I fit in? I'm in the 3-year to 10-year mark. And thank you for elaborating on the in-depthness of understanding this process. And I want to thank everybody who came in today. Thank you for coming on to the Core Kidney Health Program. Please stay tuned. We're getting ready for World Kidney Day, March 9th. It's our webinar from 5 to 7. I hope to see everybody there. And Dr. Sarkar, Dr. Lum, and Dr. Shah, thank you guys so much for the in-depthness and understanding of what kidney transplantation is. I myself, as a kidney transplant recipient, I can understand everything that you guys are telling me firsthand. I've gone through the process. So thank you guys so much for that information today. Until next time, our next webinar is every month on the 1st. Hope to see everyone there and see you guys soon.